Welcome to another CME session from SJMC. We hope you enjoy the content.
Hello, everybody, and welcome to another SJMC Grand Rounds. This is Grand Rounds number 23. Okay, and as usual, we've got a team of my excellent, eminent colleagues here from cardiology to educate and entertain you with another case-based presentation. First of all, just some housekeeping slides, yeah. All right. So, yes, you're in. Yeah, you're in. Yeah. All right. So, you need to join us on Slido.com at 1543860, or you can scan the QR code. If you have the Slido app, you can open it up. And we'll try to use this for your questions and answers, preferably. But if you're watching on YouTube, feel free to use the YouTube chat to ask us questions as well. But we prefer you use Slido. And as usual, at the end of the session, we'll display the QR code at the end of the talk, which you can scan with the MMA app, and you'll get your CPT point. Okay. So please stay with us right till the end of the session for another SJMC Grand Round. And I'm going to pass over to the presenter, who's Dr. Navin, and the rest of the panelists, Dr. Jayamala and Dr. Yap Lok Bin. Okay, so over to you, Navin.
All right. Thank you, everyone, for joining us on a Saturday afternoon for our 23rd Grand Rounds. So we are nearing the 24th, or the 2 dozen of Grand Rounds, So I hope you've benefited from the previous ones. And joining me today is my two very prominent colleagues, Dr. Jayamala and Dr. Yap. Okay, so without any further ado, let's start off with the first case. I have actually 3 cases to share today, and we'll be discussing about these cases as we go on. And the title of the presentation today is Doctor, My Neck Hurts, a Chicken and Egg Story. So maybe as we progress, you'll understand why I chose that particular topic. Okay, so the first case is a 46-year-old Indian male with no known medical problems, was recently traumatized by his badminton buddy's death due to a myocardial infarction. So, I think anyone in his place would have been quite traumatized because his partner basically collapsed next to him during a late night game of badminton. So ever since that, he's been a bit troubled, and lately he's been experiencing some pain in his neck that radiates to the left arm and chest, and it's worse in the evenings, and now he feels that it's worse after his badminton games. Also has some tingling sensation over the fingers of his left hand as well, and claims occasionally he has some shortness of breath, and very worried, has never had his heart checked, and after what happened to his badminton buddy, so of course understandably he's more worried now. So some background history: he's a non-smoker, no family history of ischemic heart disease or strokes, plays badminton 2 times a week, consumes alcohol during social events, works as an IT consultant with long hours of work, mostly online. Okay, so on physical examination, you can see that he's slightly overweight with a BMI of 26. Blood pressure was elevated, 140/100, pulse rate 72, regular. Otherwise, no other abnormalities detected. No obvious chest wall tenderness, no obvious neurological deficit, anyway, from a cardiologist's point of view. Okay, so I'll throw the first question to Dr. Jaya. Maybe you can just share with us, if you have a patient like this who comes to your clinic, what investigation would you do to determine the cause of his discomfort?
Thank you, Navin. Now, when someone comes with history of tingling and numbness of his upper limb, particularly the left upper limb, it tends to favor more a neuropathic cause for his symptoms rather than a cardiac cause. Cardiac tends to have more of an aching sensation rather than a tingling sensation. So, first thing I would like to think about is whether this is cervical radiculopathy from cervical spondylosis. But of course, that is a diagnosis of exclusion. What he's worried about is his heart, and I have to make sure his symptoms is not an atypical presentation for an ischemic etiology. So I would do the basic investigations, which is basically making sure his sugar, like his HbA1c, his lipid profile. Thirdly, of course, ECG, a stress ECG if necessary, and for his neck, at least an X-ray cervical spine.
Okay, thank you, Dr. Jaya. So I think we will agree that will be the basic first-line investigations that should be done for this gentleman. So obviously, he's in an age group where he's of Indian ethnic origin, so probably that puts him at a higher risk. His age, he's 47, so definitely we have to do all those tests, and this is the blood test done. So as you can see, his fasting glucose is definitely impaired, 6.3, normal being below 5.6, and even the HbA1c is borderline, 6%. As for the lipid profile, the total cholesterol is elevated at 5.8, and if you look at his LDL, it's about 3.7, right? And besides that, his kidney function was normal, urine protein was negative. Urine protein was done because of the elevated blood pressure, so that was negative. And this is his ECG, 12-lead resting ECG. Maybe Dato' Yap, would you like to?
I want to comment about his blood profile. Basically, this gentleman has a typical dyslipidemia of diabetes, low HDL, high TG, and some of he's pre-diabetic. So he's a bit fat as well. So it almost looks like he has a metabolic syndrome. Okay.
All right, moving on to the ECG. Dato' Yap, your comments on the ECG?
So I would look at this ECG also in the context of what situation the patient is in now. So if I saw this ECG in ER when the patient is actively having chest pain, as opposed to this patient who has a neck discomfort, I think it does put the history into context also. So the ECG shows sinus rhythm. There are P waves, consistent P waves, and in particular, there's some very slight ST depression, not like the kind of deep ST depression that we would see in a patient who's having chest pain, who is having cardiac ischemia at that point. So this ST depression is seen in 2, 3 AVF and also V4, V5, V6, very slight. I think they are fairly non-specific, doesn't show any acute MI or acute ischemia.
Yeah. So I agree with Dato' Yap. So when I saw the ECG, and I actually added on a troponin because the discomfort's been there for a week. And when I saw the non-specific ST depression, so I just sent off a troponin, but it was negative, right? And this is the further test that I did. I did some X-rays for him. In Dato' Yap, your input on this X-rays, chest X-ray, and we have a neck or cervical X-ray there.
Okay, so if I saw a patient with neck discomfort or chest discomfort, I want to make sure that there's nothing acute on the chest X-ray. So there's no obvious consolidation or mass that I can see in the lungs. The bases are clear. I can see the costal diaphragmatic angles well. There's no pleural effusion. Heart size looks normal, doesn't look enlarged. We're talking about more than 50% cardiothoracic ratio. And also, there is nothing obvious on the X-ray. I think the X-ray looks normal. So in terms of the neck X-ray, I'm looking at the intervertebral disc gaps. There's a bit of loss of disc space towards the bottom few discs. And for a person that's having neck pain, I'm wondering whether there's some cervical disease here, somewhere in there. And I think the picture might be a bit small, but there are some very slight, what looks like osteophytes towards the bottom also that I can see. So there might be some cervical degeneration or spondylosis on this X-ray.
Yeah, so I agree with Dato' Yap. So you can see, especially at C5, C6, there's reduced disc space. You can see some osteophytes. So that could explain his symptoms. If the osteophytes are impinging on the nerves and can actually cause the radiculopathy. But then again, like what Dr. Jaya mentioned, cervical spondylosis is a diagnosis of exclusion. We have here a middle-aged gentleman with, risk factors. He's obese. So I think we can't just stop here and say it's cervical spondylosis. So what was done next was basically a stress test. So if you remember, his first reading was elevated. Probably he was anxious the first time he walked into my room. I just let him rest for a while, and after about half an hour, checked his blood pressure was normal. So I told him, put him on the treadmill. So he completed the treadmill. He achieved actually stage 5, no ST changes seen, and it was a negative stress test. So, Dr. Jaya, would you stop here, or would you do any additional tests for this gentleman? Are you happy with labeling him as having cervical spondylosis with a normal stress test, or do you think that we need to take it a bit further?
I mean, there are two things here. For regards to cervical spondylosis, since he's quite troubled by pain and maybe with the radiculopathy, you may want to refer to the orthopedic, and you may want to do an MRI to see whether they need to do anything further for the neck. But coming back to this man's cardiac point of view, I mean, he's worried about his heart. He's got many risk factors. And in most instances, I would probably stop here and tell him, I guess it's time for risk factor reduction, watching your sugars and your weight. But there's something that this guy does which makes me very unhappy, and that he plays badminton 2 times a week. I think most people who know me, most of my patients, I always get a scolding if beyond the age of 40, they start playing badminton or tennis because, well, maybe being a cardiologist, I get very skewed perspective of seeing a number of patients having either dropped dead or coming in with infarcts after a badminton game. So for that reason, I may want to suggest at least some further assessment, either with a calcium score or maybe even with a CT angio, just to look to see whether this man has any plaques, coronary plaques. And if there is, then I will tell him that, hey, you need to stop playing badminton. Otherwise, you may end up with a myocardial infarction.
That's very interesting, Dr. Jaya. I didn't know that you tell that to all your patients who play badminton. All right. Okay, so that's what I told this gentleman. I told him the stress test is normal, but I think he was still, very traumatized by whatever happened to his buddy. So he kept asking me, doctor, are you sure? Are you sure? Is there anything else that you can do? So I offered him, the another option, which would be a CT coronary and a calcium score. So these are the images. So the CT coronary calcium score was about 70, and there was mild stenosis. If you can see picture A, that's the left anterior descending artery. You can see mild stenosis of 20 to 30%, predominantly mixed plaques. The white spots you see there are actually calcified plaques, and then some of this darker colored or black color spots, those are cholesterol plaques, right? So again, if you look at picture B, there's a cross section, right? A luminal view, we can actually see at the bottom part, the white spot. So that's the stenosis. His circumflex and right coronary artery, which is C and D, those were fairly normal, right? So no obstructive coronary artery disease on his CT scan. So of course he's now more convinced that he's not going to drop dead suddenly out of a MI, right? Okay, so now that we've done all these exhaustive tests and fully investigated him, now we can come to a final diagnosis. So maybe, Dato' Yap, what do you think? What's your final diagnosis for this patient, and what will be your advice to him?
So to summarize, I think this patient came with neck and chest symptoms, radiation with the left arm, and his cardiac investigations are quite reassuring. up to the point of CT scan, there's no significant coronary stenosis identified, and yet he has had some X-ray changes suggestive of cervical spondylosis. So I think one is, as you said, reassure the patient that his cardiac status is okay, he's not at high risk of MI or sudden death. Second is to address the likely diagnosis here, as well as his cardiac risk factors. So we identified on his blood test that his cholesterol was elevated, his sugars were suggestive of impaired glucose tolerance, and also he may have a longer term issue with hypertension. So all these factors need to be followed up and also monitored for him. And then to come back to the issue of his symptoms, he may benefit from some medication or some physiotherapy.
Yeah. So that's what I did with him. So I advised him to monitor his blood pressure. He was not very keen on a statin, so I said, go on a lifestyle modification and repeat the levels after 3 months. And he's still under my follow-up. And finally, I did have to start him on a statin because I told him that there's already plaques on your CT scan and you're at high risk. So, but he has successfully brought down his weight. Still playing badminton though, so maybe I have to address that. All right. Okay. So just a bit of a discussion on cervical spondylosis since you're on the topic. So basically, it's a natural degenerative process of the cervical spine, which can lead to cervical radiculopathy, or in severe cases, myelopathy or axial neck pain. So we're seeing this in younger patients these days, probably due to their work nature, a lot of them working on PCs, long hours of work. And the mechanism of neurologic compression, in mild cases, you'll just get radiculopathy, like how this patient had this tingling sensation of his fingers. But in more severe cases, if there's actually central cord compression, that can actually cause to myelopathy, where they will actually present with weakness of their limbs. So presentation, neck pain, headache, pain that radiates to the shoulders, chest, numbness and tingling, and in cases of myelopathy, they can actually have weakness of their limbs. So what is the most basic test to diagnose this? Basically what we discussed earlier, just a simple cervical X-ray, where we can actually look out for disc space narrowing, osteophyte formations, and in cases where you want to look at the nerve roots or the central cord, then an MRI will be warranted. But usually, if that is necessary, I will refer them to the orthopedic surgeons. Right? And treatment-wise, medications and NSAIDs for the pain, physiotherapy. In severe cases, they may need surgery. So, like what I mentioned earlier, we are seeing this more in a younger age group these days, probably due to their working conditions, long hours of working in front of the computer with their neck bent down. Right? So that's possibly a predisposing factor. Okay, so what is the learning points from our first case, right? So in this patient, despite presenting with fairly atypical symptoms, coronary artery disease needs to be ruled out. And in patients with high CV risk, CT coronary may be of benefit despite having a normal stress test, like what Dr. JR mentioned just now. We can actually pick up all those little plaques and then maybe advise them on more strict control of their risk factors. And in his case, probably even avoid strenuous games of badminton. And it's, like I mentioned, helpful in terms of diagnosis and also control of the risk factors. So this patient, like what I did and what Dr. Jaya and Dato Yap have echoed, advice on CV risk reduction, glucose, blood pressure, and lipids to target, management of his metabolic syndrome, and basically leading a healthy lifestyle and weight management, maybe avoiding heavy games of badminton, but I can, always do some other alternative exercise, which is safer in his condition. Vijaya, anything to add?
Yeah, just a point of discussion about this strenuous physical activity and the risk of myocardial infarction. Actually, it's been well documented, actually. Strenuous physical activity is associated with a temporary increase in risk of having a myocardial infarction, especially in individuals who do not exercise frequently. And by frequently, they mean by anything less than 4 times a week. And when you have an acute cardiovascular event in a young, healthy adult, that means a young, healthy adult exercises and then something happens, it's usually a ventricular arrhythmia. And in those patients, it's usually they have an underlying hypertrophic cardiomyopathy or some congenital coronary anomalies, some cardiac abnormality, pathology. In middle-aged, healthy adults, a lot of them, like this young man, I mean, he would consider himself very healthy. And except for the CT angio, which picked up that he actually has occult coronary plaque, he will think he's got pristine coronary arteries. What is the risk of him getting a myocardial infarction after exercise? Well, this is one study which was done in Rhode Island, and they found that the exercise-related myocardial infarction is 6.5 times more likely to occur than a sudden cardiac death. That is, they're more likely to end up with a myocardial infarction than to die. And what is the risk like? It is 1 MI in 593 to 3,852 healthy middle-aged men. So it's anything between 600 to about 4,000 because there was a big standard deviation, the risk of MI in healthy middle-aged men who do not know they actually had occult coronary artery disease. What is the pathogenesis of the strenuous physical activity giving rise to the infarct? Often it may be due to fissuring of the plaque, due to the excessive jumping around, the increased heart rate, sometimes causing destabilization of the coronary plaques. For that reason, I always tell my patients, do not try and become a badminton or a tennis champ once you're over the age of 40. They don't like me for that.
So when you talk about strenuous exercise, basically that's the two games that, or they get patients coming then, can I play futsal? Can I play rugby? So where do we draw the line? And
basically, usually it is these games, but in fact, like I said, even very strenuous. I always tell my patients, do not push yourself beyond. Once you begin to feel tired, you feel that you are stressing yourself, I think it's time for you to slow down. You cannot push yourself some people like to push. I like to push myself to the limit to see how much I pass. I say, unless you do it very, very frequently, more than 4 times a week, please do not do that.
Yeah, very true. Sometimes you see patients who come to you and then they get a stress test done, and this person has not exercised for umpteen years, and then he tries to, outdo himself on the treadmill, and then you see suddenly, even I've had patients who develop vasovagal attacks after that because they push themselves too much. So I think everything should be done in moderation and in balance. Nato, you have anything to add on?
I'm quite interested in this point that Dr. Jaya was talking about, because
I had a case recently, right?
I was on call, and there was a patient who was 55 years old who had never had any medical history previously, who was playing badminton at 10:30 at night, and he comes into ER by about midnight. The wife said that he had near collapse on the badminton court, and when he arrived in the ER, he had ECG showing acute anterior MI, a lot of SP elevation in the anterior leads. And basically, we told him that the cath lab and found that he had a complete occluded LAD. He was very, very unstable, and it turns out that underlying was a very, very tight proximal LAD stenosis in someone who never had any symptoms. And also, he mentioned he had recently, in the last few years, been doing regular checkup with regular stress tests, and has been all normal. So they were asking the very typical question is, we've been doing stress tests, and how come this can still happen so suddenly? And I think Dr. Jaya has already answered that question already. So interesting that we saw a case like that, actually.
Yeah. All right. Okay. So I think we'll move on to the second case. Okay. So the second case is a 53-year-old Chinese lady, known case of SLE vasculitis. She was on prednisolone and hydroxychloroquine. Defaulted follow-up for about a year and stopped Celsep or mycophenolate, which is one of the immunosuppressive drugs. She stopped that for about 6 months on her own. So she basically started to feel unwell at 1 p.m. with neck and back pain. Also had some abdominal and chest discomfort. She checked the blood pressure at home and it was about 160/90. But she was feeling unwell, so she decided to come into our emergency department. And the first blood pressure reading in ER was actually 220/110, right? So the impression then was this patient actually having a hypertensive crisis with active SLE, also possible mesenteric vasculitis because she was having abdominal discomfort, right? Okay, so generally she was in discomfort. So you can actually, understand the extent of her pain because she had to be given petidine. And slightly tachycardic, probably due to the pain, pulse rate about 110, regular. BP, like I mentioned earlier, was 210/110. Cardiovascular system, no murmurs heard, lungs were clear. Forgot to mention here, actually her pulses was regular. There was no radiofemoral delay as well. Mild tenderness at the epigastric area. No masses palpable per abdomen. No bruise heard. Okay, so you've seen this lady, 53, presenting with elevated blood pressure reading, some chest, neck, abdominal discomfort. What would be the first line of investigations? Dr. Jaya, would you like to share your opinion on this patient?
Well, I mean, she seems to be in a lot of pain. And of course, the first thing I need to do is, number one, try to find out what is the reason she's having pain. It's unlikely that it is due to the SLE. I know SLE tends to cause a lot of joint pains and muscular myositis, etc. But I have to make sure it's not something more acute which is causing this pain, especially if she, to such an extent that she requires petidine. So basic investigations such as ECG, a chest X-ray, cardiac troponins, and then of course, the blood pressure being so high, you would want to do your usual renal profile and assess your SLE activity with the necessary C3, C4, and the other immunological studies.
Correct. So this is what was done. And this is, I don't have the full profile here. Complement levels were also done, C3, C4. This is the most basic one that we can get it as fast as possible in the emergency room setting, right? So her troponins were negative. Her hemoglobin was low, 7.6. Her baseline 1 year ago when she was still under regular follow-up was about 12.2 grams. Her creatinine, her renal function shows that the creatinine is impaired, and 1 year ago is perfectly normal, right? And her ESR was 122. So that probably indicates that, her SLE is active. Okay, and that is her ECG. All right. Okay, so ECG, as you can see, sinus rhythm, no acute events to indicate any coronary events, right? No ST depressions, no ST elevations, no signs of LVH or left ventricular hypertrophy on the ECG as well, right?
Surprisingly, she doesn't really have much of a tachycardia on this ECG.
Yeah, this was actually not the first ECG. The first ECG when she came in was tachycardic, but this was after she was given some pain control, and I asked for a repeat ECG just to look for any progression. Because sometimes when these patients present very early, the ECG could be normal, right? Okay, and so this is her X-ray. Right, Dr. Yap, would you like to comment on her X-ray? I actually have put up two images, one which was done a year back, and this was during the current admission.
Okay, so on the left is the current chest X-ray, and on the right is a years back. In fact, I'm looking to see, the heart size and whether the mediastinum is widened or not. I would say it's very difficult to tell. The lung fields look clear. And in fact, the one a year back also looks a little bit widened in the mediastinum, and which could be unfolded aorta, the angle that we look at. The current one, the middle part looks a little bit swollen, possible, I'm not very sure. But if we wanted to do more detailed imaging, then I probably would ask for CT.
Okay, so your wish is granted.
So
Okay.
Wait, just a question. So why would you decide you want to do a CT? What are you really looking for?
Okay, in this lady, I think the main issue is that she has severe abdominal pain. The secondary issue is she has extremely high blood pressure with the background of SLE, which we know that is a connective tissue disease, which does predispose patients to possible complication of dissection. So now I can't explain the abdominal pain. I really would like to CT her abdomen, because I think there's a whole host of possible reasons for why she might have an acute abdomen. At the same time, I think it would be wise to do it with contrast, to have a look at the aorta to make sure that she has or doesn't have aortic dissection. But from the history alone, it sounds very much that she has an acute abdomen. And sometimes you'll find that these people have, obstructed bowel. They might be bleeding somewhere in the abdomen also, infection, abscess, so many things that we can identify with the CT abdomen. But we'll get a contrast as well to look at the aorta.
Because the hemoglobin had also dropped, right?
Yeah. Well, I mean, an X-ray can also give us other information. If you are thinking about acute abdomen, sometimes a perforated gastric ulcer, maybe that's causing her pain and causing her blood pressure to shoot up. You can look for air under the diaphragm. So these are the things a simple X-ray can actually give information. And I thought that, but maybe retrospectively looking, I thought that the current X-ray showed that especially the upper mediastinum looked a little more widened than it did a year back. But then again, it's not a perfect film. You can see the patient's body is slightly rotated in the current chest X-ray. Okay, so Dr. Yap, you requested for a CT angiogram. So I have some images here. Maybe you can comment on the first image here.
Okay, so this CT image is a slice across the chest with a view of the lungs as well as the aorta. And here we can see the aortic arch. So where your blue arrow is pointing is actually the aortic arch with going down towards the descending aorta. Now, from the cardiologist's eyes, I'm always looking on a CT at the vessel to see whether the whole vessel is completely white, or this is a shock finding. If I ever see this, you can see that there's actually a dark line that actually goes down across the vessel, and that will be suspicious of aortic, or confirmation of aortic dissection, basically.
So that's actually indicated by the blue arrow. You can actually see, by right, you should just see the whole lumen will be white, but now there's a line across. So one of it is actually the dissection flap with hematoma within it, and the other one is actually the true lumen. So basically the collection of the blood there is probably what is causing her hemoglobin to be low, the hematoma there, which has consumed quite a bit of her blood products. Or the other thing is it could also be an indicator of active SLE, the anemia, right? And the good thing about a CT aortogram, sometimes we even do a triple rule out where we can actually even look at the coronaries, we can even look at the pulmonary vessels to rule out coronary artery disease or pulmonary embolism, besides looking at the aorta. So this particular slice actually shows more of the descending aorta. And if you can see the next image, this shows you the arch clearly, right? So you can see the flap there within the arch as well, indicated by the blue arrow. And this again, if you look at this view, right? Dr. Yap, any comments here? You can.
Yeah. So in this view, we are looking at where your red arrow is basically the descending aorta. Now, the important thing when we see aortic dissection, the second question is how extensive is the dissection? And you can see that there's a flap on the top and then the flap in the middle section. But we are looking to see whether the front part, where you are going towards the ascending aorta, whether the flap extends towards that or not. And if it does, then the prognosis is not good and they require more towards urgent surgery or intervention. So in this case, I see that the flap is more towards the descending up to the arch, aortic arch.
So a CT aortogram, like very rightly mentioned by Dr. Yap, it's for diagnosis purposes and also for prognostic purposes, right? We're going to decide on how to manage this patient. Right? So again, this is a 3D reconstruction showing the same thing. You can actually see that the flap there, which is at the arch and also at the descending aorta, right? doesn't seem to extend into the renal arteries though. Okay, so Dr. Jaya, based on what we've shared so far, what is your diagnosis for this patient?
I mean, basically, this lady has aortic dissection, a type B. If it was type A, it would involve the ascending aorta, and it may have gone backwards to involve the aortic valve, and that, of course, the prognosis is aortic dissection. The cause is why? Probably just due to the hypertension. And why is she hypertensive? Probably because of the SLE with renal involvement. SLE per se doesn't give rise to hypertension, neither does it give rise to aortic dissections. So the aortic dissection is due to the hypertension, which most likely is due to the SLE nephritis because you can see her creatinine is dropped up.
Yeah, so most likely it's a type B, I mean, it's definitely a type B aortic dissection, secondary to accelerated hypertension. And that's probably likely secondary to her active SLE, like what we've shown through her blood parameters earlier. Right, so just some simple discussion on aortic dissection. I think we've shared this in one of our grand rounds a few months back. So there are two types of classification system. One is D-Bakey and the other one is Stanford. I tend to use Stanford because I think it's easier. That's basically just a Stanford type A and a type B. Right, so type A, it involves the ascending aorta, and like what Dr. Jaya mentioned just now, it can actually even affect your aortic valve, right? Type B, like what our patient has, does not involve the ascending aorta, right? And it's usually the arch and the descending aorta that is affected. So if you see in this picture, right, Stanford A, you can see it involves the ascending and the arch, and Stanford B, it's actually affecting the descending aorta, right? So very important because it's going to actually decide on how this patient is managed, right? So when you're talking about type A dissection, basically, since it involves the ascending aorta and also potentially the aortic valve, it carries a very high mortality and it will usually require surgical intervention. As for our case, which is a type B dissection, this can be treated medically with good survival rate. And what is the first line treatment is basically management of the patient's blood pressure. And usually that will require intravenous drugs. Most commonly what we use is IV GTN and also IV labetalol. And the aim of the treatment is to reduce the blood pressure and to minimize the stress of the dissection and propagation of the dissection. And in very rare cases of type B dissection, surgical intervention is necessary. That's usually if there is complications such as rupture or kidney involvement, visceral or limb ischemia, refractory pain, or uncontrollable hypertension, right? So what was done for this patient? This patient was basically started on parenteral antihypertensive agents. She was started on IV GTN. That is to bring down her blood pressure as rapidly as possible within a short frame of time. Then, of course, when the blood pressure is more stable, we can introduce the oral agents, right? And for her active SLE, our rheumatologist was roped in, so I won't comment much on that. And subsequently, the patient did very well, right? She was discharged after about a week, and she had a follow-up CT aortogram about 3 months later, which showed no further propagation of the dissection. Blood pressure was well controlled, and the patient is doing well. So this is a very interesting case, right? So patient comes in, sometimes you may think that the patient's blood pressure is high because she's in a lot of pain, or it could be the other way around. You know, it's because of her blood pressure which has caused all these complications, and that's why she's in pain. So what are the learning points from this second case? So bear in mind, malignant hypertension, either due to primary or secondary causes, can present with complications such as aortic dissection, or in some cases, we've seen patients presenting with hemorrhagic strokes, right? And the main cause of secondary malignant hypertension is thought to be parenchymal renal or renovascular lesions, such as in this patient who has underlying SLE. So a high index of suspicion is needed to rule out complications associated with malignant hypertension. So that's where in this case, you know, when you're doing a CT aortogram, you can actually look out for other things like what Dr. Yap mentioned, looking for any mesenteric involvement, any ischemic bowel, dilated bowel. So it's useful in that sense. So CT aortogram is basically the gold standard to diagnose and guide the management of aortic dissection, as evidence in this case. Anything that Jaya, Dr. Yap, would you like to add on?
Yeah, just a little point for discussion. I mean, how common does aortic dissection due to hypertension? I mean, we always hear it's due to Marfan, cystic medial necrosis, etc. But how often is it due to hypertension? Well, actually, 53% of cases of aortic dissection in one study was due to hypertension. And the risk, if the systolic blood pressure is above 120 mmHg, if 62% of those aortic dissections had systolic blood pressure above 120. In fact, there was a large study which just published recently, I think in 2021, where they looked at two cohorts, from the Japanese cohort as well as the UK Biobank cohort. And they found that the risk of aortic dissection at a high blood pressure is 3.07. And the risk was significant when the systolic blood pressure was above 132 mmHg and the diastolic was above 75 mmHg. Therefore, when you treat high blood pressure, besides all the other complications that hypertension can lead to, one should try to aim to target, which in most patients is less than 120, less than 130, or less than 140, but ideally less than 130, in almost all your hypertensive patients.
So actually, that's quite an interesting study because of Jaya, like you mentioned, right? The blood pressure reading is not very elevated. You're talking about pressures about 130 plus or 80 plus diastolic. So, it doesn't necessarily mean that the patient needs to present with a blood pressure of 200 or 210 before they can actually have a aortic dissection.
It's possible that the bleeding may be low at that point because he may have already bled into the either pleural space or into the peritoneal cavity because of rupture. So sometimes you don't know which.
Correct. So usually, if it's a rupture, the mortality is going to be very high. So in this patient, just a dissection, the hematoma is contained. So that's why the patient did very well. Okay, so let's move on to our third and final case. So this is a fairly interesting case I have to share with you guys today. This is a 70-year-old Indian male, diabetic, hypertensive on those two medications listed. He came in complaining of headache from the previous night, and he describes the pain as throbbing and it radiates to the neck. He took some paracetamol but was not getting better. He had no other symptoms such as giddiness, vomiting to suggest any raised intracranial pressure, low limb weakness, no chest pain, shortness of breath. He was seen by his family GP, noted to have some ECG changes based on the ECG done in the clinic, and he was given aspirin 300 mg. He's a non-smoker. Blood pressure on presentation was about 170/90, not tachycardic. Otherwise, no other abnormality detected. Okay, so that's his ECG, right? So would you like to comment on the ECG, Dr. Yap?
Yeah, and the ECG looks like a regular sinus rhythm. I'm looking to see, because your patient has a headache, whether there are some non-specific T wave changes that sometimes we see in intracranial leads. And there is some T wave inversion in the lead 3 and ABF. But I think on its own, this is probably non-specific, and I wouldn't say that this is an abnormal ECG. It looks okay.
Okay, so next, like what you mentioned, this patient came in, blood pressure was a bit high. I was worried, was there an ongoing stroke or, intracranial bleed? So I did do a CT brain. So, I mean, of course, we are not expert radiologists here, but looking at the CT brain, I'm sure Dr. Yap, you'll be able to tell us the obvious.
Well, in a patient with headache, I want to know if there's any signs of bleed. So we are looking for, bits of high intensity signal, which is like white, because blood will often look white there. And I see that the parenchyma looks quite consistently normal. I'm looking to see whether there's any midline shift, any pressure effect, and the midline is actually quite straight and normal. I'm looking to see if there's any sign of subdural, so any bleeding. Also, I don't see any subdural, so I think this CT looks normal.
Yes, so that's what I thought as well. So then investigations, just to echo what Dr. Yap mentioned just now, T inversions non-specific in leads 3 in AVF. Luckily, this patient is under SJMC for his previous follow-ups. So I actually had his old ECG to compare, and the ECG was actually similar to what was done a few months back. Troponin was negative, renal function normal, FBC normal, and his CT brain was reported as having sinusitis. Okay, so in the ward, I treated him with oral antihypertensive. I added on to his medication, right? The BP was well controlled upon discharge. He was given some painkillers during his stay as well that improved his headache and the neck pain that he had. And, because the CT scan actually showed sinusitis, and when I re-explored the history with the patient, he did tell me that yes, mornings he's been having some nasal congestion, sneezing. So, for benefit of doubt, I just got ENT colleague involved as well. So he was given some antihistamines and nasal decongestants, and he was actually discharged. So what I usually do with my patients who come in with elevated blood pressure reading, right? I will usually just ask them to start on medications, monitor their blood pressure at home, and I'll usually give them an early appointment to come back to the clinic so I can actually see how they are doing, right? So the thing that I did not mention here, the other thing is this patient also had a CT coronary done in another hospital, I think about 6 months back, which was normal. So I did not proceed further with any other cardiac investigation at this point in time.
Can I ask you, how often do you think this man's headache is due to his blood pressure? Because often we see patients coming with headache and the blood pressure is like 150, 170, and the MO ring and say, oh, the hypertensive, urgency, hypertensive, emergency, and all that fierce diagnosis. So, how common is this headache and this blood pressure?
I mean, personally, I don't feel there is a correlation, because you see people walking around with a blood pressure of 200 coming to your clinic, totally asymptomatic. And then, some people you see with a BP of 130, 140, and they come in complaining of, throbbing headache. So for me personally, yes, if your blood pressure is elevated, sometimes it may cause headache, may cause some neck pain, but it's very non-specific. Dr. Yap, anything to?
Yeah, I agree. I think it's very difficult to tell. Sometimes patients get hypertensive and then they develop a headache, and sometimes they're getting migraines or stress-related headaches, and then the BP goes up. I've given up trying to work out which comes first. We just basically give them anesthesia and treat the hypertension.
Yeah. So interestingly, the patient came back to clinic 2 days later. His appointment was actually in a week's time, but he came in earlier complaining of worsening pain. And this is what I see. All right, so you can see on his forehead, there's this little vesicles here. Also affected his eye. His eye was swollen. Okay, so Dr. Jaya, what do you think about the diagnosis based on the patient's presentation 2 days later?
Basically, yes, a bit zoster involving the ophthalmic division of the testimony.
Yeah.
And usually, sometimes the pain precedes the appearance of the vesicles by about 2 to 3 days. Yeah. So I guess that would fit in into the correct time frame.
Yeah, I mean, very interesting, because I mean, this was really, it didn't even cross my mind that, this is actually his problem. So I thought it was due to the sinusitis and probably the blood pressure. But subsequently, the diagnosis was actually herpes zoster ophthalmicus. So just to discuss a little on herpes zoster, since we're on the matter. So basically, it is a blistering and painful rash caused by varicella zoster or your chickenpox virus. So anyone who has had chickenpox before may subsequently develop herpes zoster. So we see it more in older people or those who have a weak immunity. I'm sure, Dr. Allen, you probably see a lot of those patients, your oncology patients who present with herpes zoster.
Oh, yes.
Yeah.
I mean, especially the immune compromise on steroids,
Correct.
or there's some malignancy, so it tends to reactivate.
Yeah. So clinical features. So usually you develop these blisters, and the first sign is usually just pain without any visible skin change. And later on, they develop these blisters, which in a short time will actually get crusted, or in some cases, you can even get infected. So general measures: rest, pain relief, some ointment, oral antibiotics if it appears to be infected to cover for secondary infection. And nowadays, patients respond very well to the antiviral treatment. Usually, what I usually give is acyclovir, 800 mg 5 times a day. We also have other options. And just by giving that, within 2-3 days, his symptoms resolved and patient is doing very well, right? So that's very interesting. Patient who comes in with head pain, neck pain, and in the end, the diagnosis is herpes zoster. So what are the learning points from this case? So as what Dr. Jaya asked earlier, headache and neck pain not necessarily correlates with the BP readings. Sometimes the pain can be due to other causes, which can actually cause elevation of the blood pressure in readings in an otherwise normotensive patient. So as to quote what Sir William Osler said before, medicine is a science of uncertainty and an art of probability. With that, I end my presentation. Any last learning points that Dr. Jaya or Dr. Yap want to add on?
No, I think that one should keep an open mind. Just because you're a cardiologist, just don't only look at the heart. That the patient comes to you with a complaint, and you have to look at it in total. And you should not do what I think some people do. Your heart is fine. I'm not sure what your pain is. Please go look for somebody else.
Yeah. So that's why it's good. I mean, once you make an initial diagnosis, to follow up the patient to see what is actually happening. Even I have not treated herpes zoster for many years, so I had to actually look up what was the treatment.
There's a comment on Slido. Agree with Dr. Jaya. I too give the same advice to my at-risk patients, like vigorous exercises like tennis and badminton. The arteries are stiffer.
Yes. Thanks.
Okay. There's some questions from Dr. Sunita in the YouTube chat, and she asked how to improve the HDL in the individual. Maybe I think it's the first case, despite exercising regularly.
Well, as I mentioned earlier, this patient initially he still wanted to try, lifestyle modification, wanted to do more exercise. He said he can actually do jogging, swimming, and all that. So I gave him the benefit of doubt and gave him 3 months. But coming back after 3 months, the HDL was still below 1. So subsequently, I started him on a statin. And ever since that, I can't remember offhand, but I remember his HDL levels were better. So I think sometimes, in this patient, my answer is probably a statin because he already has plaques there. So I'm more targeted in my treatment. So I want to actually prevent progression of the plaques and reduce the chances of him developing a cardiovascular event in the future.
Okay, thanks for the answer. Any other questions? I think, before I show the QR code for points, I want to show a little reminder from an AI doctor.
Thank you for watching our video. If you enjoyed the content, please don't forget to hit the like button and subscribe to our channel. Also turn on notifications, so that you won't miss our upcoming videos.
Version of you, Dr. Allen.
Yes, with more hair.
That was
please do subscribe, because I still get questions. How are we to keep informed of our upcoming live streams? If you subscribe and then hit the notification bell, YouTube should remind you that there's going to be an upcoming video. Almost every month, the SJMC cardiologist team will come to you live. So please hit the subscribe button. Thanks. Yeah. Okay. And all right. If there doesn't seem to be any questions, so I'm going to share. Tab here and oops, no. Right. Can see? Okay. All right, that's not the QR code. And here you are. That's the QR code for CBD points. Please feel free to scan with the MMA app. I already tested, it works, so you should get your point instantly. As a reminder, you need 20 points. If by now you don't know you need 20 points on the next cycle, I think you're in deep trouble. So, yeah.
Thank you very much, Alan, and thank you very much, everybody.
Yes, so and have a good weekend.
All right.
And thanks, Navin, Jeremiah, Win. I think great presentation. Actually, I was involved in one of the cases, but that was a very complex case. The lady with SLE, yeah, and she had hemolytic anemia as well, and aortic dissection, and renal. She was very, very difficult, but she has done well, I must say. Yeah. Okay. All right. So I hope everybody has a good time, a good weekend. Stay safe. Cases are going up. Mask indoors. Okay. Bye bye.
All right. Bye bye.
Thank you. Thanks a lot, everybody.
Right.
I think
Thank you,
it's okay.